Hello, and welcome to today's webinar focused on supporting providers of color in the pediatric workforce, made possible through support from the Robert Wood Johnson Foundation. I'm Armel Cazot, a Senior Program Officer at the Center for Healthcare Strategies, and I'm delighted to welcome all of you today, and honored to have had the chance to co-create this webinar in partnership with our amazing presenters and CHCS colleagues. We hope you'll enjoy this webinar. Your feedback is very important to us, so please take a moment to complete the survey that will pop up at the end of the session. Next slide, please. So for those of you not familiar with the Center for Healthcare Strategies, or CHCS, we are a policy design and implementation partner, and we work with stakeholders nationally and other state partners to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid and related programs that help address health-related social needs. On the next slide, we'll take a look at our agenda. We're fortunate to hear from 4 wonderful speakers today, presenting on the need to build a representative and supported pediatric workforce, strategies to recruit a diverse workforce and develop anti-racist training programs, the importance of centering patient voices and self-reflection when training future pediatricians, and best practices to promote staff self-care, celebrate successes, and reduce burnout. These presentations will be followed by a panel discussion and then a Q&A, where we will take submitted questions from the audience. Speaking of questions from the audience, to submit one at any time during this session, you can click on the Q&A icon located at the bottom of the screen. So on the next slide, we are again grateful to hear from our presenters and panelists. We have Dr. Danielson, a pediatrician and clinical professor at the University of Washington School of Medicine, Dr. Tom Cho, a pediatrician at the Westside Family Health Center, who is also the medical director of Denver Health's pre-health programs, and an assistant professor at pediatrics at the University of Colorado's School of Medicine. We'll also hear from Dr. Doshi, a pediatrician at the Children's Health Center at San Francisco General Hospital, and an assistant professor of pediatrics at UCSF, and then from Elizabeth Castro, the strategic support manager for the Adobe program at the University of New Mexico's Health Science Center. So very excited to hear from our fantastic panelists from mostly on the West Coast, but a little bit around the mountain region around Colorado and UNM as well. So very excited to have them on today. Dr. Danielson will facilitate the panel discussion, and I'll facilitate the Q&A with your questions. All of our presenters are engaged either as a core partner or as a pediatric pilot site in a CHCS initiative called Accelerating Child Health Transformation, which I'll describe on this slide. So we all know that all children and their families across the nation need access to a healthcare system that serves their unique needs and supports opportunities for lifelong health and well-being. But the current system fails too many children, especially Black, Indigenous, Latino, and other children of color. We need to expand the focus of pediatric care to go beyond just medical care, providing immunizations or treating illnesses. We really need to focus on supporting more preventive and holistic care that fosters connections between children, families, communities, and the systems they interact with regularly. The significant challenges of the pandemic, coupled with a national reckoning on racial inequities, amplify the imperative for the field to push for a more comprehensive approach that focuses on child and family well-being. For the Accelerating Child Health Transformation Initiative, CHCS is working alongside a fantastic array of partners and is building on amazing work, past and present, done by others in the field. On our end, we are convening leading experts, pediatric providers, and very importantly, family and patient advisors across the nation to explore, identify, test, and share innovative ways to accelerate the transformation of child health care beyond medical care. We're also so grateful to be working alongside amazing CHCS colleagues on this project, including Hannah Gears, Lawrence Kennelly, and Dana Robertson, among many others. On the next slides, so through insights from subject matter experts, including ones with lived expertise, CHCS has identified 3 key strategies that are integral to child health transformation: adopting anti-racist practices and policies to further health equity, co-creating equitable partnerships between patients, families, and providers, and identifying family strengths and helping to address health-related social needs. We'll drop in the chat a link to a synthesis report we developed with practical recommendations for stakeholders to consider adopting to transform child healthcare delivery along these strategies. The report also identifies some accountability and financing levers that are crucial to accelerate support and sustain improvements in pediatric care. So this webinar came about as conversations we've had with pediatricians and family advisors, including those on the call today. And we're looking at anti-racist policies and practices that can be adopted. Diversifying the pediatric workforce is key. When healthcare professionals reflect the communities they serve, it leads to greater health equity, enhanced patient care, and improved health outcomes. For example, when Black providers care for Black newborns, the mortality rate of Black infants is cut in half, and other racial disparities are reduced. On the next slide, you'll see that the current pediatric workforce, however, lacks racial and ethnic diversity. People who know me well know that it's hard for me to resist showing some data to help frame the issue at hand, but the voices you'll hear from our presenters in just a couple of slides, who are themselves part of the pediatric care workforce, will tell the whole story. So data-wise, this graph from the American Board of Pediatrics shows the percentage of pediatricians by race and ethnicity and by certification status. Underrepresented providers in medicine, in light green on the graph, include Black, Latino, Native American, and Native Hawaiian and Pacific Islander providers. This is in contrast with non-Hispanic white pediatricians in the dark green in the graph. Only about 15% of pediatricians, all the way from trainees to practicing and fully certified pediatricians, are of those races and ethnicities, compared with 41% of children in the US that are reflective of those races and ethnicities. The good news is that the percentage of future pediatricians that are currently in training who are underrepresented in medicine at 70% is slightly higher than the current percentage of certified pediatricians who are underrepresented in medicine, and so that's promising. Unfortunately, when looking at the number of total pediatricians and trainees, the field is experiencing shortages overall, which are projected to worsen in the years to come. And so on the last slide that I'll show today, there are also some stark geographic maldistributions of pediatric providers in communities in the South and in the rural Southwest and Rocky Mountain states. Some of the rates that you can see equate to there only being one pediatrician to provide care for nearly 3,000 children. There are also maldistributions in inner cities. In New York, for example, the pediatrician rate per 100,000 children is 3 times worse in the Bronx than in wealthy Westchester County just north of the Bronx. All this brings us today to share and discuss strategies that can support existing providers of color in the pediatric workforce, but also ways to recruit others to enter the field. And so without further ado, I will now turn it over to Dr. Danielson for some framing remarks and insights on those issues. Thank you so much, Dr. Danielson.
Thank you, Armel. I'm really happy to be with you all today and have a chance to have this conversation. I'm really excited about the presenters and the information they're going to share with you. So I won't take too much of your time, but I really want to say how glad I am to have been part of the Accelerating Child Health Transformation work over these many, many past months. And the partnership with the Center for Healthcare Strategies has just been incredible. We're going to talk about this challenging issue of the future of healthcare. And there's a certain uncertainty about that. The uncertainty about the future of healthcare, it represents both some challenges, but I also want to say some important opportunities to co-create and co-cultivate inspiring work environments for us all. There's a complexity regarding this healthcare workforce discussion that we should acknowledge from the outset. People's fatigue and the reasons for contemplating leaving are complex. The barriers to entry are layered and complex. And so I think it's important to think about this from a holistic perspective. No singular, no simple solutions. But that's not to say that we're talking about something too big to take on. There's no lack of good ideas, good approaches, and good solutions. There are people doing brilliant things, from broadening the pathways leading to healthcare careers to enhancing the experience of healthcare professionals throughout their careers. I also believe the topics we're talking about and have been talking about over the past many months at ACHT, the issues of belonging and anti-racism, the issues of community and family voice, the issues of co-creation and co-opportunities, hold important insights and offer actionable solutions to create a sustainingly positive work environment. Our choice to be in this field is a wonderful and a kind of weighty one. The roots of our decisions as pediatricians to enter this path reach way back and involve many different kinds of sacrifice and choices. It's an understatement to say that it takes a bit of intentionality and persistence to enter this field. And people leave this field for many reasons too. I say that it's likely many who leave are not leaving for just one reason or just one episode or just one experience. For me, at least, just if I can speak personally, as a person who found primary care to be the very best job I'll ever have, it wasn't just one experience, although they did tend to fall under a similar category of untenable racism, the kind that affects my community in ways much greater than just my own privileged position. And for me, even after resigning in protest, my adoration for this field remains intact. It's the best job I'll ever have and the greatest honor, and something I won't let others disconnect me from, if that makes any sense to y'all. And I'm grateful to continue to be part of the pediatric care family, part of your family of professionals dedicated to serving our communities. Primary care pediatrics exists at the merging intersection of community and the more intensive healthcare system. We might hold a bit of diplopia, a double vision coming from these communities and these healthcare realms and different perspectives therein. The pressures and tensions that suffuse healthcare, the traumas and challenges that pervade communities are both doubly impactful on the sites of primary care. We hold some knowledge of how families we see face the inequities of economic status, the transgenerational harms of racism, the geographic maldistribution of resources, the focused environmental toxicities, the basic undermining of dignity, and the threats to family integrity. We also absorb hefty doses of secondary trauma ourselves while we manage our own fatiguing experiences. And all the while, our days are also full of joy. We bask in the privilege of sharing time with amazing families, wonderful communities, inspiring cultures. We work with incredible teams, which are much more like families, with a kind of caring dedication no one could ever doubt. We in primary care have an opportunity that can be very rare in other realms of medicine, to see people when they are well, and celebrate and support that wellness. We have the ultimate honor of glimpsing the future, the universe of possibility of what could come next, and the undaunted enjoyment of what exists now, all found in the eyes and energy of our youth. We work on an interface of many sorts, a convergence, and we know we have what is so often the first opportunities, the front door to medicine's sort of opportunity to welcome family voice, to lead healthcare conversations. We know that anti-racism, promoting a sense of belonging and dignity, these are health interventions. We know that when families enter spaces that center their voices, and when young people enter spaces that has people that look like them, those too are health promoting interventions. No more need to prove the case that racism and all of its biasing can harm health. We know these things, we know them. And I think that knowing all these things that each of you knows in your own way, we deserve something. We deserve to work in environments that uplift and promote and promulgate all those things we see in that space of convergence. We deserve spaces that help us to listen and learn and process the many lessons our families and communities are willing to share and to teach. We deserve to be in spaces in healthcare that help to heal the traumas we see and mend the fatigue that we feel. We deserve to cultivate and advance in our field the abundance and joy that is here, is still here, has always been here. So now I'll descend from this high altitude talk and start to invite us to move into the real work, the tangible efforts that are happening all around us today to help us see that vision of a sustaining workforce. You have a chance to hear today from people who are doing good work and to bring us closer, and I hope it will spark both inspiration and a sense that these efforts are part of an ecosystem approach. You'll think about what parts of these efforts you can in some ways incorporate or support or promote, and what other parts of the ecosystem you may want to delve into yourselves and grow and nurture and cultivate. You'll hear from a few great folks today who are, in fact, you, a subset of you, making changes which aren't easy. They aren't easy, and I know that each of you holds the kind of expertise we need to see realistic change happen. This conversation comes from people who work in that interface, work in that convergence, just like so many of you do. Because ultimately, we have to acknowledge that we are the ones that we've been waiting for to help navigate, co-inspire, collaborate, and co-create. We are the ones. We're the ones that we've been waiting for now, and now is actually the right time. Now is actually a necessary time. Now is one of the most important times for us to be having this kind of conversation. So I feel like it is timely and right, and I feel ready to invite the voices among us, the voices that have been doing this work for a long time and have wisdom to share. And I want to hear from your inspirations, your questions, and your ideas as well. With that, I'm going to hand it back to Armel to carry us into this conversation with these incredibly brilliant people. Thank you.
Thank you, Dr. Danielson. We are so fortunate to have your voice and your leadership on all of this work. You've been so brave to share your story, and we're just so fortunate to have you both on this call, but also in the work. And we are thankful for you to facilitate the panel discussion afterwards. So thank you so much. So now we're going to turn it over to Dr. Tomcho, who's going to share some of the strategies that they've used to recruit a diverse workforce and to help develop anti-racist programs for their trainees. Thank you so much, Dr. Tomcho.
Hi, thank you so much for this opportunity. And thank you to Dr. Danielson for that wonderful introduction. I couldn't agree more. This job as a primary care pediatrician is the most rewarding thing that I've ever done and the most humbling thing. I learn so much every day from my colleagues, from my patients, from families, and it is just such a joy to be with people, especially when they're well. So thank you for that. And I'm very grateful to the Accelerating Child Health Transformation Program. It has been such a wonderful experience these number of months and a great community of learners. And I am very appreciative for this opportunity as well. So today, I'm excited to share some of the fantastic programs that we have here at Denver Health that work to bring children and youth into the field who would otherwise not necessarily have a path visible to them to share this wonderful profession that we do. Next slide, please. As we're all aware and has been stated already today, there are significant disparities in health outcomes among different populations in our country. And this was painfully evident in the COVID pandemic, but long predated the pandemic. We also know that health outcomes and health equity are improved when our workforce is diverse and representative of the communities and populations that are served by our healthcare system. Education is an important social determinant, and opportunities need to exist so that all can explore and learn. And equitable education is one of the best ways to address social determinants of health and improve economic mobility. Next, I'm going to briefly describe some programs that we have here at Denver Health for high school and undergraduate students that can provide exposure to healthcare and create potential pathways in the field. Next slide, please. The first program I'm going to discuss is our Medical Career Collaborative, or MC Squared. And this is one of the programs that we have for high school students interested in health careers. This program exists for juniors and seniors and provides mentorship and hands-on experiences for these students. Our goals are to provide support for these students in their education, both high school and beyond, and also to provide concrete opportunities for certification programs that can lead to income while the students are in their education and experience during that time. These students are invested in our hospital system. They often receive care with us, so we really want to invest in them and have them return in some capacity when they finish their education. Next slide, please. The mission and goals, as I mentioned, are to provide exposure to healthcare careers to high school students from diverse backgrounds and support them as they go through their certification programs and then ultimately get their degrees. And we ideally want to hire them back here at Denver Health. Our goals are also to improve their contacts and build mentor-mentee relationships as they progress through their education. Next slide, please. So some of the concrete components, during the junior year, these students have a paid internship at our facility and are onboarded through our HR as employees. So they truly get that learning experience that can help them in the future. They're matched with a department and one particular mentor. They also, while they're working, will have some seminars, formal presentations, simulation, field trips, workshops, and other things to enhance their learning. During their senior year, things are a bit more individualized and they receive post-secondary coaching, writing workshops, and a number of other professional development workshops. Fortunately, we have many levels of trainees at our facility, medical students and residents, and so we will often use our medical students as the coaches and writing coaches because they're closer to the experiences of the high school students and are able to identify with them. And that is really enriching and rewarding for both the high school students and the medical students. We're also really focusing on creating an alumni network so that we can keep in touch with our MC Squared graduates and working on a young professionals network that can serve as peer support. These interns are employees of our facilities, so they have access to our sponsored certificate and training programs as well. Next slide, please. The next program I'm going to discuss is our Healthcare Interest Program, or HIP. Next slide. The HIP program is a partnership with some local universities and involves a combination of experiential opportunities, mentorship with faculty, and seminar sessions. The students spend a year in this course and get 1 credit hour for each semester. These students are identified by academic advisors at their universities as likely to benefit from more non-traditional or outside the classroom supports and opportunities. So these are students that aren't necessarily in a traditional academic or progressing well in an academic path, but really tend to benefit from those outside the classroom supports and unique supports that we can provide. The program actually started with students who were really interested in medicine, but has broadened to include students interested in lots of other healthcare fields, such as nursing, APP work, child life, social work, and then other therapies such as PT, OT, and speech. Next slide, please. Each year, we work with 15 to 30 students and conduct bi-monthly seminars as well as their mentorship. And these seminars involve a range of creative programming, things like simulation, lectures from faculty, panel discussions, and workshops, again, done by an array of different levels, both trainees, residents, and attendings. And it's been really great to have students with such varied interests in healthcare because we can really talk about the interdisciplinary team approach to healthcare, which is, I think, a really unique perspective for these students to bring then to their graduate programs and careers beyond. The seminar time also allows the students the important time to debrief experiences they've had while working with their mentors. These experiences that they have can be so intense, and so sharing with the group is really important for their health and well-being as well. Next slide, please. And this slide, again, just shows how we're thinking longitudinally to nurture and build a diverse staff and provider community. In particular, to really aim to achieve our long-term aim here of creating a representative provider and professional base that meets the needs of our population. Next slide. Thank you. We've really found that these mentorship programs are so well received, and you can see a student comment at the top of the slide here. I've seen that in Denver Health, there's solutions to connect providers to patients regardless of their background. Denver Health providers work together to create communication and equitable healthcare experiences. These solutions from various professionals make healthcare accessible and practical. We've actually had some students participate in both programs, the MC Squared one in high school and HIP one in college. Then they subsequently have enrolled in our CNA and EMT training programs, went to graduate nursing school, and are hired back. And it's so fun to see them advance through the organization and really feel invested as if this is their home. These programs are rewarding for mentors as well. And I have a favorite quote of mine from a mentor that we were able to have participating in our program last year about how participating as a mentor was really so rewarding and life-giving for him. Next slide, please. Now turning to some new initiatives. We've recently started a program that hires youth health educators. These youth teach us, the clinic staff, about how they'd like their medical care to look. They participate in leadership and professional development, and then work on creating presentations to deliver to provider and staff groups. We've had one so far, and it was very well received. It allows us to elevate the youth voice into these important conversations. The youth are supported in their professional development, but then also empowered to develop youth-driven programming, essentially flipping the clinic. So they're coming in and telling us what works best for them in the visit and beyond. Next slide, please. Lastly, I'd like to very briefly highlight a project that has been led by a brilliant group of residents from the University of Colorado and Children's Hospital, Colorado. And these are the Pediatric Resident Simulation Modules. This is their project and one that could really be an entire webinar on its own. So I hope that my slides can do justice to introduce what they've done and the wonderful work that they've started and they've led. So a small group of residents performed a needs assessment that involved residents, faculty, and community members in order to develop these simulations. And on the slide, you see their goals and objectives. They have the goals of recognizing bias and microaggressions in clinical scenarios and work on practicing the art of being questioned, along with simulation-based learning, calling in and calling out. Distinguish between cultural competence and cultural humility, knowing that they're working with patients who have significantly different lived experiences from their own. They're practicing patient-focused interviewing, empathetic feedback, and then reflecting on their practice and identifying changes that they can make in their clinical care. Next slide, please. They have 3 scenarios in their simulations: a social determinants of health screening scenario, a scenario of a family with limited English proficiency, and a scenario of identifying and responding to microaggressions expressed by the care team member who may describe a family as difficult. Then afterwards, they finish with a debriefing session. The reach of this program so far has been broad, as the majority of our residents have participated in the simulations. And we're so grateful that this project was able to be supported by Accelerating Child Health Transformation Funds and Dr. Okada from Denver Health. The residents were surveyed before and after the simulations, and we've found statistically significant change in the art of being questioned, the difference between cultural competency and cultural humility. Residents note being better skilled at responding to verbal and nonverbal cues, indicating emotional discomfort of a patient or family member in their encounter, and feeling comfortable in addressing an interprofessional team member about a bias or microaggression in order to improve care. So these have been fantastic, and it's an amazing start that these residents have made, and I'm hopeful that this project is just going to be able to grow. Next slide, please. And I would just like to acknowledge that this work I'm just a part of this work. The pre-health programs team, our directors, Vicki Ryan and Marissa Valeris, work very closely with the students and are exceedingly dedicated to them and their growth. And I wanted to name all of the Children's Hospital Colorado pediatric residents and faculty team who have made the simulation project a reality, and then express my gratitude and acknowledgement for the ACTH initiative for assistance with funding our simulation modules. Thank you very much.
Thank you so much, Dr. Tom Cho. That was a fantastic presentation, and we're just so impressed with the work that Denver Health and you and the rest of your colleagues are doing around workforce development. We definitely have a number of questions that have come up through the chat, so we'll save some of them. We'll try to answer some of them offline, but we'll save some of them for the broader conversation at the end. And again, just that mentor and mentee quote, it just really speaks to the fact that it's so important for the trainee to have those experiences, but for the existing providers to be able to have the opportunity to interact with the pediatrics that are in training and that are working their way through the pipeline. So thank you so much for all your work. So we're going to turn it over now to Dr. Doshi, who's going to share how they've been able to capture patient voice through human-centered design and using that strategy to train their next generation of pediatricians. Thank you so much, Dr. Doshi.
Thank you, Armel, and good morning and good afternoon, everyone. Really appreciate all of you deciding to spend some time with us on this webinar, and looking forward to hearing what's surfacing for you all and questions and comments that are coming up. Really want to express some gratitude for all of our colleagues and the organizers behind this webinar. We're talking about some very important topics and where I feel like is kind of the future of our, hopefully, our workforce and how we're hoping to change clinical care. Like Dr. Tom Cho was saying, and Thank you again for all of these introductions. This truly is like the greatest gift, Dr. Tomcho and Dr. Danielson, both. This is the greatest gift that we have to be in this work. I'm a pediatrician, a primary care pediatrician based at the Children's Health Center, which is our outpatient clinic based within our Safety Net Hospital here in San Francisco. Many of you might be familiar with San Francisco General Hospital. We are a busy, amazing, chaotic space. And what I'm hoping to do today is share a little bit about some work that I led about a year ago called the Listening Project that was fundamentally grounded in really wanting to understand and learn more directly from our community, mostly with the goal of truly just amplifying our community's voice and really understanding and learning how can we transform clinical care. One of the nice consequences that came out of this project is, or one of the outcomes, I should say, is that it not only was helpful for our own clinical processes, but it actually had us thinking a lot about workforce and how our patient voice and community voice can actually be part of the way that we think about broadening our workforce. And so that's kind of what we'll learn about today together. I will, next slide, please. So as we're thinking about this work together, and these have been some of the guiding principles that have really grounded this work and have kind of been true to all of our approaches in the way that we think about really listening to our community. And I can imagine that many of these guiding principles may also resonate with many of us, kind of like Dr. Danielson said, we are all here, we are all in this together, approaching our third year in this pandemic, working within the healthcare system. And these guiding principles not only really infused our work for this project, the Listening Project, but have also been core to the way that we think about possible changes for the future. So these 4 guiding principles, just to name them for all of you, are proximity, mostly that nothing can replace being proximate to our patients' experiences and the gift and privilege that is. Really a desire to imagine a new narrative. We all hold a courage to imagine a new narrative and a new reality, and one that promises to be more healing for all of us. Really holding on to hope that can fuel action and accountability, that we are all in this together. And often that means taking action and doing things differently. And that can sometimes mean doing uncomfortable things. But again, part of this work, part of all of us across the country getting together to think about these issues within ACHT has really been about pushing us to do uncomfortable things. Next slide, please. So what I wanted to do was just talk for a couple of minutes around the process that we employed for this Listening Project, mostly to help give a sense of why we did it a certain way and what it really taught us. We actually employed, next slide please, a human-centered design approach to understand the context of the everyday lives of our patients, to really think about starting to problem solve. And our process was really focused on children under the age of 5 or families with young children, just given that at least here in San Francisco, and I'm sure across the country, really thinking about the needs of these families as they navigate a range of systems and are presenting clinically with many issues that affect longer-term health and well-being, still seems a huge area of growth. The core principle of human-centered design, I'm sure many of you have heard of this, is to really approach problem solving by focusing on empathizing with each stakeholder in the ecosystem to understand their unique challenges and unmet needs. For us, our stakeholders are our patients. And so the process that we put in place was really to kind of start with our patients and learn alongside them and with them. It's meant to be repeatable and iterative, so it's meant to change as we go. It's not really designing on behalf of them, but it's really for our patients, designing with them and really trying to listen and amplify what they need from their perspective. Next slide, please. And this feels important to me just because it's often not, human-centered design is often not a go-to modality in terms of the way we think about academic research or health systems research in the traditional sense. As a pediatrician here working within a very robust clinical setting, I have found it to be a very, very helpful approach to really push us to imagine a new narrative and kind of deeply address health inequity. It's meant at its core, human-centered design to center and elevate the experience of our community members and really be willing to redesign certain processes and systems. I do think it's a growing field in healthcare research and just the way we think about service delivery. So I encourage all of you to think about human-centered design as a way to really focus on the people. Like I was mentioning, one of the beautiful outcomes of this work was how we are allowing this to elevate not only the experience for our patients and community, but also for us as staff and also for us as our next generation of pediatricians. Next slide, please. So this is just a brief slide. We were not going to have enough time to talk through the entire listening project, but just to give you all a flavor, the listening project essentially followed 14 of our families who were patients at the Children's Health Center over the course of about 10 months. And this gives a breakdown of kind of some of the things clinically that they were facing, an archetype as we think about, trying to capture maybe some of the ways that we find that families are really struggling with navigating and getting connected to resources within kind of this early childhood ecosystem. So we were able to recruit and consent with and kind of work with a group of 14 families over the course of about 10 months to really just get a sense of how are things going with them? What does it look like to kind of be trying to access so many different services, especially during the pandemic? So this was in about 2021 when we actually did this work. I put this graph up, I put this table up here mostly because I imagine that a lot of these archetypes or these kind of families that we're seeing resonate with what many of you may be encountering in your own clinical settings. And the snapshot that we had and what we learned from them really allowed us to think real deeply around what can we be doing to better meet our families' needs, and what can we be doing to be showing up in a way that feels meaningful to our families. Next slide, please. So what does this all mean? Our listening project, again, focused for 10 months following these families over time. We were able to record interviews and reflections with our families to see what was working, what wasn't, what were bright spots, what were challenges, and as they were navigating care. And that actually allowed us to build an entire library of audio clips, as well as maps, visual maps that kind of followed families over time to see what the reality was as they're navigating care and also seeking the best things for their children. Next slide, please. All of the audio content that we were able to receive, all of the maps that we were able to create kind of inspired a good amount of action for us. This captures some of the insights that we took away from what we heard from our families. And again, I don't think that this will be necessarily new to many of you who are dedicated and working in this field. But I think sometimes it's really nice to be able to ground what we're learning in what our patients and community is saying. And how are we using that to challenge the way that we currently deliver care and the way that we're building out our workforce. Some of the things that I'll just kind of call out on this slide is as we've learned from our families and kind of been able to present this work in a lot of different settings, one of the things that has really surfaced is what are we doing to broaden our workforce to meet the diverse needs of our community? And how are we really thinking about culturally concordant and race concordant care? A lot of what we heard from our families is that so much of the time, care can feel provider dependent. So it's kind of luck of the draw of who you got to see that day. And that has allowed us to really think about what are we doing to support our providers and to really build a shared sense of accountability for our families, and that it's not necessarily just about who you saw that day, but that it's done with intention. I'll let you all be able to, think about some of these insights. And again, as questions come up in the panel, happy to weigh in and see what's surfacing for you all and what's coming up for you based on where you work as well. Next slide, please. As we come back to our grounding principles, some of the things that were really on my mind to share back with you all was this project really essentially we were able to kind of distill so much of what we heard and the maps that we were able to create to kind of follow patients' experiences into about an 1.5-hour presentation. And myself and one of my co-colleagues who kind of designed this work, we basically took the project itself and all of that content on a listening tour, and we took it to our clinic staff and our hospital leadership and our educational leaders within the UCSF pediatric residency. And it became very, very hard to not want to do something differently once you were listening to the voices, and once you were kind of grounded in the realities that all of us are truly still trying to show up here and be and redesign and reimagine the way that we deliver care. This project was actually able to create a foundation for a new trauma-informed care curriculum for UCSF pediatric resident trainees. And that now is part of their core, one of their core components of their residency training, to really get a sense of listening to so many of these audio clips, what services for you as a trainee, and what is it going to instill in you to kind of show up differently. I will say anecdotally, for myself, I've really heard from so many of our trainees who are also trainees of color, or who are trainees who are showing up where lived experience has not been discovery, but lived experience is just so core to who they are. They have really acknowledged how this being part of their curriculum and this work being kind of front and foremost in the way that they're hoping to kind of develop their own clinical lens and approach has been a huge kind of boost and a huge morale boost around seeing themselves not only as pediatricians, but also knowing that they've also oftentimes seen themselves in the community that they're serving. Part of also one of the joys that I have seen about taking this work and kind of elevating it and allowing other people to kind of reflect in it together is it's really allowed us as a clinic, as again, like an FQHC, a federally qualified health center, kind of in an urban environment that is at baseline going to be crazy and chaotic. It's really allowed us to integrate storytelling and reflection into our work, into our actual work days as healthcare teams, so that we can also build a healing environment, so that we can show up better for our families. An example of what this looks like for us is we have now, since about the fall of last year, blocked an hour of time during the week for our entire clinic staff to be together. So it's not necessarily after hours, and it's not a volunteer time. It's kind of our entire clinical staff comes together, our front desk staff, our providers. Everyone comes together to spend an hour to share stories and reflect on maybe a challenging situation, or something that could have been done differently, or how could we better respond or de-escalate certain situations. And I will say that now, nearly about 6 months into that process, it's been an amazing way to see how our teams can also come together, so that we are able to show up a little bit stronger and a little bit more whole for our families. The hope for me from this work, and I think every day, I think Dr. Tomcho certainly feels this as well, is this next generation that's coming is, really ready to push us and keep us accountable to what we are all talking about. There's a real sense of fire and urgency, which I find just incredibly inspiring. And I think learning from our next generation and the way that they're not necessarily willing to accept current state and how it needs to change, including asking for, kind of bringing up the often uncomfortable and necessary questions around what are each of us doing as academic institutions or clinical, clinical settings to show up for our community. I think that has been certainly an element of hope for me in this work, and what I can imagine many of you may also feel. And it's also kind of pushed us. This listening project was an example of, again, how elevating community voice, especially when it was so close to many of us, has had many of our leadership teams and many of us just in our clinical setting really think about how are we reallocating what always will feel like finite resources to elevate our communities of color, and how can we ensure that that's kind of part of infused in all of the work that we're doing. I will say that for again, I think as we think about workforce, and as we think about broadening the way that we design care teams, and really thinking about who's coming through the pipeline, being very transparent about some of these realities, and also the way that we are outlining and dedicating resources to the people who need it most, and also, you know, being able to support our trainees of color has been not necessarily the easiest process, but also an important one. And I think it's important, it's been most important, as I've heard from many of our trainees, to know that there is a space where they will be supported, and also there is a space where their presence matters, not only for our community, but also for our the way that we think about care delivery. So again, just very appreciative of this time and space to be able to share back some of this work that we're doing in San Francisco, and looking forward to hearing what surfaces and comes up for you all. Thanks, Armel.
Thank you so much, Dr. Dorsey. Your passion and dedication for this work is so apparent in your community, but the broader community at large is so lucky to have you focusing on those hard conversations that need to be had, empathy, family voice, but a lot of staff reflections that need to happen. And it's just so rewarding to hear that, you know, the young generation coming up along the workforce is really pushing for a lot of that change. So that's fantastic to hear. So we're going to turn it over now to Elizabeth Castro, who is going to share how opportunities to support not just pediatricians, but also extended care team members, including family navigators, through promoting staff self-care, celebrating successes, and reducing burnout. Thank you so much, Elizabeth.
Thanks, Armel. Next slide, please. So I want to give you all a general idea of what the Adobe program at the University of New Mexico is doing. So we are a wraparound program for high-risk adolescents and their families. We have a primary medical care, we have psychiatric care, we have intensive case management with our family navigators, education support, therapy, and a law clinic through UNM Law School. Our clinic is built slightly different than other clinics across the country, where our family navigators are the core team members of our program, and all of the other portions of our program kind of wrap around the navigators. So it's built slightly different. I'll give you all an example. We have had a mother with 3 teenagers, an adoptive mother in her late 70s who had congestive heart failure. And a navigator was doing a home visit with one of the law clinic students, trying to get living will set up for this family. And the navigator got to the home and the mother was just not well at all. And the family navigator was able to actually call our primary medical team and have them come do a home visit to get them to actually get this family taken care of, because the mother was not actually willing to come into clinic. So our navigators have a lot of say in the way our families are being taken care of. Our demographics, we try very, very hard to represent our population. So our patient population, as you can see here, is 85% Latinx, 10% Native American, 3% Black, and 2% white. And our provider population is closely mirrored at 65% Latinx, 28% white, and 7% Black. That's something that's really important to us, as we know that, like everyone else has said, that our patients have better outcomes when the providers that they are seeing represent themselves. Next slide, please. So I'm going to talk a little bit about promoting self-care for our staff and our providers. I am coming not as a provider, but as an administrator. And I think administrators often get a bad rap that the bottom line is what we're focused on, but really I am, I'm sure, one of many who is pushing to kind of flip that we need to be focused on self-care. We need to be focused on retention, because it's highly expensive to not be focused on that, but also when you have good staff, there's no reason to not keep them. So focus on self-care, really talking about what is self-care. One of the things that we are focused on here is the ability to stop working. which is a very generalized term, but really it means taking a break from processing work problems. When it's time to clock out, it's time to clock out, and that means not checking emails. That means not taking phone calls. Really focusing on your staff and providers' ability to be home and be with their own personal lives is so important. Going into that, the ability to take time off, focusing on letting your team know that you want them to take time off. I think we, again, as administrators, are focused on the bottom line and productivity, but really what we have found in this program is our productivity increases significantly when people take time off. And then next, we are focusing on acknowledging personal issues in the work setting and how they actually affect work. I think as an administrator or manager in general, we hear, leave your problems at the door. This is work and you don't need to have personal problems here. But the truth of the matter is humans don't work that way. And so you have to be willing to acknowledge personal issues and how they're affecting your work productivity. So how can we as administrators and leaders support this? We need to have a lot of buy-in due to the expense of turnover and the negative impact that turnover has on patients. We need to build a culture around self-care. I will say from the minute that I interview somebody, I talk about self-care. I talk about how I want people to take time off, how important it is to have your personal life outside of work, because that the ability to not have that just increases burnout significantly. And be really clear on expectations. What does that mean? What does it mean to take time off? What does it mean to focus on self-care? And then lastly, why do we need to focus on self-care? As I said, the burnout rate is obscene in healthcare. I will say in our relatively small program, we have not had somebody actively leave our program as a staff or a provider in almost 3 years, which is huge, especially being that we're in the middle of a pandemic still. New Mexico is one of our places that are still pretty high in numbers. So we need to focus on self-care in healthcare, really to reduce secondary trauma. All of us are dealing with obscene amount of secondary trauma. And then as Dr. Doshi was saying, dealing with a lot of these cases that are extremely complicated, our own personal trauma gets layered upon patients' trauma. And we, I think, need to really be aware of that as administrators and leaders, and dealing with the ability to handle personal trauma on top of our patient's trauma. Next slide, please. So one of the things that we like to focus on here at UNM is celebrating successes. I think in the healthcare world, our losses can be significant and completely overwhelming, especially in the situation that we're in right now. Wins tend to be small and they tend to be overlooked. And so we are focusing on a formalizing time to actually celebrate. So we have weekly meetings that includes our staff and our medical team. And we focus on the new and good. What has happened this week that is new and good, so that there's not, maybe it's as simple as I was able to get somebody on food stamps that I haven't been able to get in 2 or 3 months. Or maybe it's something bigger, like we've helped move a whole family into stable housing. Maybe it's big, maybe it's small, but really having the time to focus on those positives helps people really kind of end the week in a positive way. And then the next slide will talk about really our self-reflection, our reflective supervision that we provide. So this is one of the key factors that we think helps reduce burnout. We provide weekly supervision, reflective supervision to every employee individually. This, I will say, is incredibly time consuming, but it's not as time consuming as having to replace people. So really this reflective supervision focuses on the relationship between the supervisor and the supervisee. It's built on collaboration, choice, and trust. We discuss individual cases, what we can do differently to achieve the outcomes desired. We also discuss personal wins, concerns that are impacting the person really at the human level. So again, kind of focusing on, are there issues going on in your own life that's impacting your ability to perform appropriately or positively in this position? We also discuss personal and professional growth in those weekly meetings, and really come up with a plan to kind of continue that personal and professional growth with people. I think one of the things that I have heard back from our medical team specifically is that this is something that does not happen in most other clinics, and their ability to kind of talk about situations that have happened in our clinic gives them the opportunity to both move forward and kind of release the stress that has come along with the situation that they're dealing with. So it's been a really positive thing, both for our family navigators, our education team, and our medical team as well. Next slide, please. So I'm sure there's probably questions on how we're able to actually provide this type of support. So this program currently is funded partially through state funding, making the case with data and returns on investment. I think we, again, as administrators are looking at the financials a lot of the time, and we can see here that the ability to retain staff it prevents turnover of patients. It prevents, it keeps the continuity of care very formal with having our patients have consistent medical team, have consistent family navigators. We also have Medicaid reimbursement. I think across the board, Medicaid reimbursement needs to increase, but we have the ability to bill for our family navigators, which gives us a small return for their time. And really looking at what needs to happen to make this more common across the system. Again, increase reimbursement rates and increase diagnoses that qualify for those reimbursement rates. I think on top of that, really focusing as administrators and leaders on not just the bottom line in this moment, but what is the long-term bottom line, and how do we support staff to stay so that that long-term bottom line is actually positive. Thank you so much.
Thank you so much for the great presentation. We know how much work you all do to support the staff, and your retention rates are just through the roof. I know you've mentioned that you often have providers within your larger healthcare system who try to get to work with the populations that you work with and through your program, just because they hear how supported they are in the work that they do, and dealing with complex populations is just something that requires a lot of support for the staff when considering all of the layering of trauma. So thank you so much for sharing that, Elizabeth. We're very appreciative of that. So we have some questions already that have been submitted. Please do feel free to share additional ones while we go forward with a panel discussion. I'm going to turn it over to Dr. Danielson, who's going to lead a panel discussion with our presenter. Thank you so much, Dr. Danielson.
Thanks again, Armel. And I'm inviting all the panelists to come on screen and come off of mute, and let's have a little bit of a conversation. Amazing stuff. I'm going to preface, because I'm in awe of all of your work, and I've got a personal promise not to promote exceptionalism as a pathway to change. So despite in my heart feeling like you are all incredibly exceptional, I also want our audience to feel like these are not things that just require just one or two amazing superstars to get them into space, but they're actually applicable to any workspace. By the way, we are working on cloning each of you, just in case we need to fall back on that too. Dr. Tomcho, Meg, I was so impressed with the work you do. And I just got to say also, you have some of the best acronyms ever. Like, I'm just saying, I'm assuming that you couldn't say E equals MC squared, equity equals MC squared, because it was probably too copyrighted. But I've been told by my wife that I'm extremely post-hip. And so I completely identify with that too. And I hope someday to be a hip mentor, because I think that sounds really cool. The ways you talk about the relationships that you have with students is really powerful and beautiful. And I want to challenge with good curiosity around how to make sure that students that aren't already destined to be on the path to medical school or other health professions are also actively recruited. Sometimes the stuff you do could be like the perfect resume kind of enhancer. And I know that your mission is different than that. And I wondered if you could talk a little bit about making sure you're actually widening the path for those who might otherwise have been overlooked.
Yeah, thank you, Dr. Danielson. I really appreciate that question. And it's one that has been asked by our team here and our administration here. And I don't know that I have the right answer, but we do work really hard to, we have an application process for the students coming into both programs, and we ask them to write essays to explain not just their interest in medicine, but who they are and their background and from where they're coming, and work intentionally on those that don't have other connections. So if there's a family member in healthcare, or even, you know, any kind of relative beyond the immediate family, we try and not that we want to exclude kids, but we really don't. If anyone has another connection, we offer them opportunities that around job shadow, other things that our hospital system offers. We're also really working to attract undifferentiated students, not students that come in and say, I want to be a doctor, but students that say, you know, I had this type, we've had a lot of experience and a lot of students interested who are new migrants to our Denver community, new arrivals, and have had some pretty traumatic experiences with our healthcare system, and have been very open and have had some really touching stories that they've shared in the course of their essays and then subsequent interviews. And those are the students that we want to embrace, that are really looking for these opportunities so that they can change the experiences that they've had for others. So I hope that answers your question, but we're really looking for undifferentiated students.
That's really good. It really matters the way you enter into that approach and who's there to invite students into that space. Each of you use such powerful terms, like, you know, that move me and make me think and make me want to be more curious. I love, like, the use out of curiosity yourself, the art of being questioned, which to me also speaks to the art of being able to question, the ideas of being able to call in to good behavior or into a inclusive space rather than just calling out, which can feel like people are being excluded. Just wondered, I don't know, in some ways that feels like such an important practice for all of us. Other ways to extend that kind of work into practicing pediatricians, practicing healthcare providers as well. Have you thought about sort of verticalizing that kind of approach?
Doing the simulation with current practicing,
yes. Yeah, and the whole art of being questioned. Yeah.
Yes, we're working on bringing that to our network of federally qualified health centers, and really working to expand the great work that the residents have done with our attendings and our providers, and not just the providers, but the staff as well.
Love it. I love it. Nidhi Doshi, Dr. Doshi, may I bring you into this conversation a little bit more? There's such fluidity between all of your three very different but very related presentations, and I just love the way you create this space and the way you build opportunity throughout careers for BIPOC providers and all providers as well. And sort of similar to that, being better at questioning, you talked explicitly about inviting discomfort in a way that I find really important and intriguing. I just wonder if there's an example you could put into practice, an anecdote you could share, even a personal experience if you wanted to, or something like that about how you saw the welcoming of discomfort rather than the running away from it come into practice in an important way.
Totally. This was something that I was thinking about even as Dr. Tomch was talking about these simulation experiences and this idea of calling in. You know, when our clinic across the board, the Children's Health Center, started these, even the concept of these all hands meetings where you would close clinic for 1 hour. You would just say, we're going to close clinic outside of our one walk-in clinic that needs to be open for, you know, EMTALA regulations. When you would close clinic for an hour and say with intention, we are all going to have to be together. And I think part of this is because we are in this kind of peri-pandemic setting, a lot has to be rebuilt. I mean, yeah. A lot has to be rebuilt. And if we're showing up with a willingness to acknowledge that we need to rebuild, that we need to invest in ourselves so that we can show up for our community. When we started these all hands meetings in the fall, it was really uncomfortable. It's all staff. So it's our front desk staff, it's our nursing staff, it's our providers, it's our behavioral health team members, it's everybody. And it, you know, it didn't feel comfortable. People were waiting to kind of just like get out of there, you know, like nobody really necessarily wants to show up. And it took consistency. It took being willing to create that space for several months. And again, it's 1 hour in it during a workday once a month. It took 4 or 5 times, not, I wouldn't say 4 or 5 times, but maybe by the 4th or 5th time, there was a real sense of, I'll see you at the all hands meeting, or, oh, I can't wait to see what we're going to talk about at the all hands meeting. And I think there's also just something powerful when you think about workforce around inviting everyone into that conversation. Yeah. It's not just for the pediatricians. It's right. Not just for our front desk staff. It's not just for leadership. It's for everybody, because our patients are encountering everybody when they walk through our clinic. And, you know, the listening project for us really gave that sense of, we had some families talk about how, you know, they check in with the front desk, they check in with the nursing staff, they check in with the provider, and they just keep getting asked the same questions over and over and over again. So we had a mom say, like, why are you surprised when you get attitude from me by the time I see the doctor? And I mean, we all need to sit with that. Why, you know, we shouldn't be surprised. We should probably own up to why that's happening, and then think as a team, as people, what are we going to do differently? So it was definitely uncomfortable. I'll say, even for me, it was a little uncomfortable. Like, you're thinking about the patients you have to see today. You think like, oh, maybe I can just chart prep and not go to this meeting. I don't really need to go. And, you know, these are small incremental steps. We had, you know, again, our clinic, just to then I'll stop, but our clinic is one clinic in our big kind of safety net hospital. So we have been doing these all hands meetings in a separate outdoor space, and it's right outside the surgical, the outpatient surgical clinic, and we're a trauma center. So there's, you know, generally it's a pretty busy outpatient surgical clinic for adults. And one of the staff members happened to come out to like take a phone call, and she saw all of us. She's an eligibility worker at that surgical clinic. And she was like, what is going on here? Like, what are you all doing? Like, you all are from one clinic. We were like, yeah, this is our all hands meeting. This is us showing up to kind of spend some time reflecting together because things are hard. And she was like, dang, you know, we need to do this. And so, I mean, it actually feels good once you do it, but it takes that intentional willingness. And like, it's not something you can ask people to do at 5 p.m. It's not something you can ask people to do as a volunteer effort. This has to be part of the workday.
That's beautiful. Got to spread that far and wide. I was going to say spread it like Omicron, but that's really not going to be a great answer. Elizabeth Castro, I wondered if I could bring you into this conversation, and I just love the way you're approaching and institutionalizing self-care, and the way in which you actually make a value prospect out of this from a business perspective. I just wonder if there are other ways that you can help me, because I know I've been that person who's created some false dichotomy around mission versus business sustainability or something like that. And in this particular time, when it does feel like we're running on under-resourced models, sort of like crisis plan perpetually. How do you help to break down that false dichotomy that mission is actually business and supports it both ways? And also, how do you help us kind of navigate these conversations at a time when everyone feels like they're short-staffed or under-resourced to some extent?
So that's a good question. I think, of course, coming from you, I think, one of the things is, I think as administrators, kind of in our background, we're kind of taught very intentionally that like the bottom line is what matters. But really kind of being able to reframe it in your own mind that yes, but is really important. And I think I had the before this position, I had that mindset of like, this is what we are focused on, this is what we need to be focused on. And then really after seeing my own supervisor really teach me this way was like mind-blowing. It really kind of changed the way that I think about administration. And I think, really presenting like the return on investment, like is one way that you can talk to administrators. Like, okay, this does take time, just like Dr. Doshi and your hands-on deck meeting. That takes time, it takes intention. It's an hour that we could be seeing patients or we could be doing X, Y, and Z, but really focusing on the well-being of clinic and clinic staff is long-term just going to produce so much more for the bottom line that it really, I think that's the way to talk about it. And I think really coming at it to leadership, that this is something that across the board, we have to address this. We have to address mental health care in healthcare, in our healthcare staff. And this is such a small way to make sure people are okay. I think is just something that we need to all kind of push forward on our leadership to make sure that across the country it kind of is paid attention to.
So beautiful. I really, really appreciate that perspective and that learned experience. You're sort of bringing your own mentorship experiences into this process and how you're continuing to grow. I wanted to have a more just broad question for any number of you to kind of talk a little bit about. It's around recruitment and retention of BIPOC providers. There's historically maybe been a sense that if you're brown or Black, Indigenous, LGBTQIA, Two-Spirit plus, you go through some indoctrination going into healthcare. You adopt a new language, you wear different clothing, you have hierarchies that are built in there. And these are all things that also sometimes push individuals to feel like they're leaving behind their culture and their identity. And I know we're in a time when we're pushing back on that, but I wonder if you have, any of you have ideas or examples or ways in which you help to make sure that people bring their full selves into the workspace, and that those workspaces actually appreciate the whole selves, that I don't have to talk different, or I don't have to leave my emotional passion at home when I come to work, so that someone doesn't judge me for being a angry Black man or for some other component of who I am. I just wonder if you, and any of you, all of you, have thoughts about how to bring our whole selves and encourage our whole selves in the workspace.
I think this is such an important question. I feel like this is something I think about a lot with our trainees, just, pediatric residents across the board, and even not even necessarily medical trainees, but interns who are coming in to join other teams, like community health worker interns or behavioral health team interns. One thing that comes to mind for me is I have seen in the moment when they are able to see a patient or a family where they themselves are celebrated for like who they are at their core, whether it's a comment that somebody might make about them, you know, in a positive way around, I really like that tattoo, or I love that sticker on your badge, or, you know, truly, like some of our patients being like, it's so nice to see a Black doctor. I'm so glad I got to see a Black doctor. I, as a educator in this space, I think it's important we like hold that and celebrate that and call it in for what it is, which is, and so many of our residents of color, like oftentimes they are feeling like, why am I even doing this? Like, what's the point? I'm literally in a space where everybody thinks it's okay the way that we treated this family. And like, that was my mom with me as a kid. Like, what is the point here? And I think there is something really powerful in being able to hold what many of our, I can speak at least for our trainees, know is that's why they're actually here. That has been what's brought them here. So I feel like a lot of times in these spaces, I'm just extra cognizant of when they're calling out things that should not be done, should not have happened, that we don't just dismiss that we do call it out and give it the space it needs. And that we, you know, like Dr. Tomcho's doing, even with the simulations, that we call in real moments of hope and joy and celebration. Feels small, but I think it's important.
Huge. Thank you. Anybody else want to share on this?
I would just add in, I think part of that is also building a culture around that level of acceptance. And I think it really starts kind of at the top. We consider ourselves kind of the black sheep in our system. And we definitely, I would say, tend to be more accepting of tattoos and people's cultural differences in our team. And I think just really focusing on that as a culture, I think is really important to kind of process that through.
Beautiful. Thank you.
And I would echo what both Dr. Doshi and Elizabeth said, and as we've really tried to build, as we've looked at what we're doing with our youth educators and how we're doing the professionalism training, to not have the professionalism be having people have certain things that they need to do so that they look like our administrators or look like our executive staff, that they're able to come as their authentic selves, and that in and of itself is professional and accepted and celebrated.
And it's a continuing process, isn't it? It's a kind of move in that direction. I'm going to do a quick check-in with our gracious host, Armel, and see if there more time or if we should start incorporating some submitted questions.
Yeah, so thank you so much, Dr. Danielson, and for all of you, this has been a fantastic panel discussion. So we do have a number of questions. So actually, we want to make sure we answer as many of them as we can. So we're going to turn over to the Q&A. And so the first question is for Dr. Tomcho, related to your programs that you've done. Someone was wondering about the recruitment of high school and college students. Are there any specific recruitment strategies that you've done that have been effective? And also explaining what the term calling in and calling out is, since it's not necessarily something that everyone is familiar with. Thank you.
Of course. So to address the calling in and calling out first, and please others on the panel jump in if I'm not explaining it exactly perfectly. I think of calling out as when something really needs to be stopped. There's a conversation or something that was said that just is not, you know, we need to not move forward, and there needs to be something that said that this is not okay. We need to stop this conversation and change how that was stated. And then calling in is approaching a situation with curiosity, like, tell me more, or I need to understand better why, or how that term was something you felt appropriate to use in the setting, or something a little bit maybe softer because the situation doesn't require like a hard stop. Others, am I explaining that? Okay. And then to address that, how we're recruiting, I don't know that we're doing anything magical. We message our high schools and have good relationships with them. And so when there's faculty at the high schools that know students that may benefit from some out of the classroom experiences or from some support that's not traditional in the classroom, particularly with the college students. The advisors that we have relationship with at the colleges really know those students that tend to like more experiential or hands-on learning, and so they help with recruiting in that way. And then our providers are all well aware of the programs, and when they have a patient or a family that they have a relationship with or seems interested or would benefit, they also can send them our way. So we use all different ways to recruit our students. Thanks for those questions.
Yeah, thank you so much. This is a question I think I might direct to you, Dr. Danielson. So how can we help address the problem of BIPOC students and residents being hyper-scrutinized and remediated at a higher rate than their white peers? Recruitment of BIPOC folks is important, but how do we stop losing so many who do not complete their training or end up having to complete their training at a different institution where they started?
Well, to me, a lot of this is what these amazing people have been talking about this is about an ecosystem effort, not a singular point of emphasis effort. And for some reason, humans, we like to solve big complex problems with really simple singular solutions. And one consequence of that can be like really trying to recruit, but not creating an environment that really supports the different identities that are brought in. And it's a terrible recipe for creating a really difficult, high turnover environment. Another thing is, what I love about some of the conversations we've had is how much vertical integration there is. And one of the beautiful things about this field, whether it's pediatrics or any of the health related fields, is we have instant verticality. We have this connection to people with 25 years of experience and 6 months of experience. We have people who are super degreed, if that's important, and folks with the real in community experiences. That kind of opportunity for vertical connection, for unsiloing roles, and for making bridges and spaces for voices to matter is really significant, especially when you're talking about lifting up BIPOC staff workers and things like that. I think that there are ways to recognize that there's an extra set of skills that are brought into a workspace by recruiting and retaining BIPOC folks and folks with experiences that mirror those most impacted in the communities that you're serving. And I also think that some of the time, until you have leadership that is both representative of those communities and that sets and enhances culture, because culture beats strategy every time, right, Elizabeth? Then it's very hard to overcome some of the challenges that you mentioned, Armel. But I would invite, y'all have much more talented and gifted answers than mine, so maybe there's something else you'd want to add on.
Anyone else wanted to add on to that?
I was just going to say, I think this is a really important question. I think for a lot of us as academic institutions, historically, there isn't necessarily a lot of transparency around some of these processes, and it can feel for trainees to be kind of like very vague, or I don't know why this is happening to me, or like what's going on. I think for any of us in these positions where something like that is happening, I just think all of us as people in academics supporting these learners, like there just has to be some more, again, like intentional time and space given to that person so that they also feel heard and that there's a sense of support around them. And that in whatever ways there can be advocacy around, it's almost like that calling in approach. Like then how are we as educators and going to the academic leadership to say, I would really like to understand more about what might have happened here, and like what is the process in place for support, and what are the other factors at play. Generally, I have found that people aren't resistant to those conversations, but oftentimes we are all just too busy to even have them, which is hard. It's hard. Yeah.
That makes sense. Thank you for sharing that. 100% agree with that. We have another question that I think I'm going to pass on to Elizabeth. So what are some, I know you talked about how the supervisor that you worked with helped you understand sort of the strategies and the benefits of how you approached better supporting staff that you work with. And so what are some key skills for non-clinical professionals that they need to develop to help to continue this kind of important work of retention and supporting staff?
I think honestly, one of the things that I focus on more than anything is empathy, again, at the human level. Like, we are all people, we are all going through different issues, and understanding that it doesn't matter how many letters you have behind your name, you still have human problems. And so really kind of focusing on the empathy and being an empathetic leader, I think is my biggest strategy. I don't ever want my staff to feel like they can't have human problems because they have to perform their job duties. I think that's, for me, probably the biggest thing to focus on. Yeah.
That makes sense. Oh, Ben, were you going to say something?
No, just really appreciate that answer. And I want to encourage us to figure out ways not to make it seem like especially you three are unique individuals in a space, but that this is the kind of work that can happen anywhere. I just wondered if there's anything we can say to make sure that we're kind of conveying that message even through these answers.
Yeah, that makes sense. 100% agree, Dr. Danielson. Definitely something that it takes all of us to do this work, and each of us can help play a role in different ways. And so it's definitely an all hands approach. So I don't know if Elizabeth, there's one more question that came in for you, and I don't know if you're able to answer it in 1 minute, but any advice on how to sell leadership or administrators on the need for the kind of long-term investment that you all are pushing for?
Yeah, I think, like I mentioned before, really using like return on investment or those financial things that administrators tend to just we like numbers. So really showing through data that this is something that's important and can long-term impact the healthcare system in a positive way, I think is how you go about it.
Perfect. Thank you so much. So I think with a minute left, we're going to conclude. I wanted to say a big thank you to all of our presenters for sharing your work, your passion, your insights, to Dr. Danielson for facilitating such a wonderful panel discussion, and to all of you for listening in and for submitting your questions. You will all receive an email with a recording of this webinar and the slides. Feel free to share with colleagues and networks. And thank you in advance for filling out the survey. We hope you have a wonderful rest of your day. Thank you so much, everyone.
Thank you all. You make me really hopeful about the future of pediatrics.